Alright, well let's look at some of the different tissues and organs that can be affected um, by the radiation. Um, First of all, we will look at the homeopathic system, which includes the bone marrow, circulating blood, lymph nodes, spleen, and thymus. Um, the bone marrow tissues include um, the really radiosensitive cells, right? The stem cells. It also includes other cells like blood cells, fat cells, and connective tissue stroma. Um, and you know this bone marrow, um, it can consist of either red or yellow, where the red marrow contains a large number of the stem cells and fat cells, um, and are generally in specific locations in terms of the bone. Um, let's look at these figures, which show the radiation-induced depletion of bone marrow tissues. Um, you know, with the homeopathic cells in mice, observed after a radiation of 6.5 grays. So on the left is without radiation, and on the right is with radiation. The structure on the right after being irradiated, you can see it's kind of meshwork, kind of like the lines that sort of sort of almost like mixed cells, and this is a meshwork of stromal cells, the supporting network, and then you get the large patches in between, which is the patches of fat cells. While the red blood cells in the blood are relatively resistant to radiation, erythroblasts in the bone marrow, which is the undifferentiated cells that will differentiate into the erythrocytes or the blood cells. These erythroblasts are undifferentiated and very radiosensitive. So, I mean, you could say the same thing about all the stem cells in the bone marrow. They are all radiosensitive. Erythroblasts, the precursor cells for red blood cells, are the most radiosensitive though. Myelocytes, the precursor cells for white blood cells, are the next most radiosensitive cells. Low doses can result in a decreased cell numbers, but recovery to pre-irradiated numbers can occur quickly, at these low doses. Whereas, when you go to moderate or high doses, this can have a more severe decrease in the cell populations, and potentially even destroy all of the stem cells. Now this might be something that is desirable, for example, prior to bone marrow transplant, but in general is kind of a bad thing. So the circulating blood is generally considered, radio resistant, with the exception of the lymphocytes. The cells are mostly non-dividing, differentiated cells, and we don't have to worry about the decrease in the circulating blood immediately after a radiation. However, the circulating blood will reflect how much damage was done to the bone marrow, and ultimately the stem cells in the bone marrow, by the radiation. But when will we see these effects? Like how sensitive and what turnover time we're looking at? Well, the turnover time that these cells have will play a huge role in the lifespan of the mature cell type in the circulating blood. So, for example, red blood cells that circulate maybe for 120 days, uh, once those aren't being replaced, then you'll start to see um, quite severe effects on the individual. Um, here's a graph showing the decrease in different cells in the days following an irradiation. The lymphocytes decrease quite quickly within a day, and also you could start to see a decrease quite early in terms of dose. Maybe like zero point 0.1 grays only. The granulocytes, these also drop quite rapidly at doses that are quite low, maybe 0.5 grays. And so these are the cells that are very radio sensitive. In contrast, though, the erythrocytes, the red blood cells, these are much less radio sensitive, and these cells don't drop as quickly or to the same extent. So the lymphocytes and the granulocytes are both types of white blood cells, and a sudden drop in these can leave the body susceptible to infections. The red blood cells, while not as affected by radiation, are important for blood clotting and carrying oxygen in the blood. And when all the cells are decreased in number, this particular condition is called bone marrow syndrome, or the more sort of Greek term, I guess, pancytopenia, where pan is meaning all, cyto meaning relating to the cells, and penia meaning to decrease or to be deficient. So pancytopenia. In terms of the doses, while cell concentrations can be seen to decrease at very small doses, maybe even as low as 0.1, at least with the lymphocytes, generally a significant drop in cell concentration doesn't occur until around 2 to 8 grays of radiation. So diagnostic radiation and nuclear medicine does expose to blood to low doses, and that, while that might have a slight effect, you wouldn't expect to see any drop in blood cell concentrations. The doses just aren't that great. However, when we talk about radiation therapy, especially if it's occurring near the bone marrow, this can significantly deplete cell counts, and this can result in feeling tired or short of breath or having a higher risk of infection, and so that is something that needs to be taken into consideration. Let's look at the skin next. So in terms of the structure of the skin, the top layer of the skin is the epidermis, and then there's a layer of connective tissue called the dermis, and then beneath that is a layer of fat, and then there's the muscle. The basal layer, which exists basically at the bottom of or the base of the epidermis, this is where the stem cells are located, and the epidermis cells are mature and non-dividing, and so it is the immature dividing stem cells in the basal layer that are replacing those, right, that are rapidly dividing, and for that reason they are the most radiosensitive. So as we lose skin cells from the surface of our skin, it is the division of the cells in the basal layer that will ultimately replace these lost cells. So, uh, so when it comes to acute changes to the skin, um, it is really the basal cells in the epidermis that makes the skin sensitive to radiation. So that's what's happening when we talk about these acute changes. Um, Typically, the first thing that we would see would be just a slight inflammation of the tissue. Very quickly, though, and acute changes, when we talk about 10 grades, about 10 to 15 grades, is when you start to get erythema. This is the sort of basically a redness of the skin, and that's what's sort of being shown here. The other effects include the dry or moist desquamation. So the desquamation is just a fancy word for saying the loss. So you're just losing skin, right? So because of the radiation, your skin is just sort of flaking off. Now the dose required for the erythema to occur is around 10 grays. Some people put it between 10 and 15, but it's around that range. And was once used as a measurement of dose, known as the standard erythema dose, or SED. And you still actually sometimes still see this. It's still used. We'll talk about that in a second. You can also get necrosis, or just the death of the tissue, but that would require quite high doses. So as I said, the images are here are erythema, and these are from patients who were receiving fluoroscopy. So they were undergoing coronary artery stenting, and to be able to visualize and know exactly where they're putting the stent, they were x-raying the patients, but they were doing it as almost like an x-ray movie, right? That's what fluoroscopy basically means, and being able to guide with some precision where they were putting the stent. And so they were exposed to, obviously x-rays do irradiate. Usually the amount of radiation will be quite small, but if it's a movie, then you're continually being subject to that for a prolonged period of time. So in terms of the late effects, then, because often the epidermis is able to regenerate, and you might expect minimal chronic changes to occur, but they can occur, and some of the things that you can see as atrophy. So basically, this is just the thinning of the epidermis. You can also see like fibrosis as well, which I haven't put on the slide, but that would sort of go along with it. You're basically just you can get scar tissue. You can also get changes in pigmentation, and alopecia is the loss of hair, so you can damage those hair follicles and things, and you can get other things like ulceration, and we talked about necrosis. The basically just destroying the cells altogether, destroying the skin. But that would be pretty extreme. One area that is concerning is cancer, and that's because the cancer could possibly occur. You really don't know if it's going to occur or not, but if it does, it can occur many years after exposure. So one of the big issues is obviously sunburn, and we're all told to wear sunscreen, because the UV rays from the sun can damage the skin and result in skin cancers. Um, and we talked about the standard erythema dose, the 10 to 15 grays that is required for erythema to occur. The standard erythema dose, or SED, is actually still used for sun exposure. You still do see it used in the literature, less for other things, I think. In terms of diagnostic radiology, though, and nuclear medicine, you shouldn't really be getting any effects to the skin, and this is true for most of these, right? We're not seeing, unless the doses are really high, you're not going to see much damage. Radiotherapy all depends on how much the skin is being targeted, or how much the skin is being irradiated. So with radiotherapy, it can be quite severe, but it all depends on the cancer being treated, and also, interestingly enough, the patient's response plays a role as well. Or maybe it's the as the procedures happening, based on the size of the tumor and things like that. Some patients may require more radiation than others. But the severity of the dermatitis in patients receiving different types of radiation is included in this table. And so on the left hand side is a grade of how severe the damage is. And it goes from 0 to 4, from no change to severe change. Interestingly, there is a grade 5 that's not included on this table. Grade 5 is reserved for we have completely destroyed the tissue, so that would be like there is no skin. You do get some people though who are getting quite severe. So in terms of like a grade of 1, that might be like a sunburn, right? So those people just had sensitivity and a bit of redness, bit of for sunburn. But as you go all the way up to 4, that's like a serious burn. That's going to require some medical intervention. That's not something that you can just sort of just ignore. So the effects are quite large. The next organ we're going to look at is the digestive system. And the radiosensitivity of the digestive system really varies as you go from the mouth all the way down to the rectum. So moderate to high doses of radiation are required to produce inflammation in the mouth or oral cavity, and also the esophagus. This inflammation is called mucositis in the mouth, or esophagitis in the esophagus. In terms of the stomach, though, the stomach is a little more sensitive to the radiation, but it's really the small intestine that is the most radiosensitive portion of the gastrointestinal tract, and that's the area that we're really concerned about. The colon and the rectum are not particularly radiosensitive, similar to like the esophagus. So let's look at the mouth and the esophagus. As we mentioned, moderate to high doses can cause inflammation in both the mouth and the esophagus. However, high doses of radiation to the esophagus can cause atrophy, right? Atrophy is literally just wasting away. Ulceration, which is damage to the lining. Fibrosis, which is like the scarring, making scar tissue. And esophageal stricture, which is basically an abnormal narrowing of the esophagus. Now, in the images shown here, the radiation-induced esophageal stricture in the mid esophageal area is shown on the left. And then the balloon, which is being inserted under fluoroscopic guidance, which we talked about fluoroscopic, that X-ray movie, is shown in the middle. And the idea is you really want to sort of put this balloon in there and then open it up. And that's sort of shown on the right. So on the right is the reduced stricture 1 month after the balloon dilation. So being able to repair that thing. Sadly, for this particular patient, the symptoms reoccurred 2 months later. So, but for a little while that worked. The next part of the gastrointestinal system is the stomach. And so ulceration, atrophy and fibrosis can occur in the stomach with sort of moderately high doses of radiation. But in general, the stomach is more radiosensitive than the esophagus. The small intestine is where we're a little more concerned. The small intestine is the most radiosensitive region of the GI tract. The lining of the small intestine consists of these sort of finger-like projections called villi, and they basically aid in the absorption of digested materials into the bloodstream. And so the cells on the surface of the villi are non-dividing. These are mature cells, and they are regularly lost, right? They are regularly needing to be replaced. And these cells must be replenished by cells, by the stem cells, which live in the crypts of the Liber Coon. Now, the cells that exist at the base of these villi then, these are rapidly dividing, undifferentiated stem cells. And so radiation damage in the small intestine is mostly a result of the damage to these cells. So here's an image of what happens to these villi upon irradiation. So as the crypt cells are destroyed, maybe by lower doses of radiation or low dose rates, they might still be able to recover. And even loss of villi, like even if you destroy one of those the villi, the finger-like protrusions, they can actually still replaced by existing villi. So basically, the crypts can split into two, and then you can have two crypts, which is kind of remarkable, really. But they can recover at moderately low doses. High doses, though, are going to kill more cells, and the villi will then start to become flattened, and the intestines will experience ulcers, hemorrhaging or internal bleeding, fibrosis, lots of the scar tissue forming, and ultimately necrosis. You're just going to kill those cells. And that's just sort of saying what I just said. So the last part of the gastrointestinal system is the colon and the rectum. The colon and the rectum can behave in a similar way to the esophagus in terms of its response to radiation. The rectum is more resistant to radiation than say the stomach and the small intestine, but you still can get chronic effects in the intestine. Mainly you can get like intestinal strictures, which are those narrowings that we saw for the esophagus. You can also get obstructions and adhesions. So this is where scar tissue surrounding the gut either compress or restrict the large intestines, and then they can cause like nausea, vomiting, cramping, obstipation. There's a lot of effects that these things can cause. So to summarize the digestive system, um, in terms of the effects of diagnostic or nuclear medicine procedures, the amount of radiation is not a threat to the digestive system. However, radiation therapy can cause damage to the small intestine, especially when treating ovarian cancer. Um, However, except for its use in palliative care, radiotherapy has been largely abandoned in the management of ovarian cancer, just because chemotherapy works better and is generally less toxic. Um, but you know, acute side effects of this treatment might include nausea, vomiting, you know, diarrhea, the usual sort of the usual sort of things that you would get for the digestive system. Let's move on to the male reproductive system. So we've already talked about the male reproductive system. So we have the mature adult sperm cells, the spermatozoa, and these are fixed, post-mitotic, and not radiosensitive. Less differentiated cells that replenish these more mature cells are more radiosensitive, and chromosomal damage and changes to the DNA can potentially be passed on to the fetus, and this opens up the quite worrying possibility for mutations to occur in the offspring. So the rapidly dividing undifferentiated radiosensitive cells, the immature spermatogonia, are what accounts for the radiosensitivity of the testes. After irradiation, there is still a period though of fertility because of the radio resistance of the mature sperm cells already present. However, this is followed by a temporary, or depending upon the magnitude of the dose that you're being irradiated with, perhaps even permanent sterility due to the loss of the immature spermatogonia. So the spermatogonia would ordinarily be dividing and replacing the mature sperm cells as they are used. But you know, permanent sterility, which occurs around 5 to 6 grays, or temporary sterility, which you know typically for a dose of around 2.5 grays would last for about a year. That is because of the spermatogonia being damaged by the radiation and not replacing those mature sperm cells. So in terms of the doses that you'll be exposed to with X-rays or nuclear medicine, they're very small, and there's always the possibility of mutations occurring. But you know, generally, testicular shielding can be used, which is essentially like these small lead spheres that fit over the testicles. In terms of having to shield, in terms of worrying about this, this is obviously much more important for radiation therapy, where the higher doses can cause temporary or even permanent sterility. So consider the plot where the x-axis shows the distance between the testicles and the inferior field margin. Essentially, the beams of radiation are around 200 to 300 centimeters squared in area, and what we're looking at here is the distance from the edge of those beams to the testicles. And then on the y-axis is the percent of this radiation that is scattered and ultimately hits the testicles during a pelvic radiotherapy for rectal carcinomas. So you're looking at up to 20%, and if you and in this particular radiotherapy, 45 grays were administered. So 20% of 45 grays is 9 grays. So more than enough to cause permanent sterility, which is why obviously this is a concern. Now, unlike the male, the female reproductive system, the reproductive cells are not constantly dividing and replacing those lost through menstruation. And an ovum is released from a mature follicle at ovulation, and the follicles are characterized by size, so small, intermediate, and large. And it's the intermediate follicles that appear to be the most radiosensitive. So an ovum is released from a mature follicle, and then there's an initial period of fertility occurs after moderate doses of radiation due to the presence of already mature follicles. However, temporary or permanent sterility will occur later due to the destruction of the immature radiosensitive intermediate follicles in this system. A dose of more than 6.25 grays is considered necessary to produce infertility, but this is sort of like an average number, and it really depends on the age and the fitness of the individuals. Obviously, a large concern is the chromosomal damage, and during the initial period of fertility, passing these genetic changes onto the offspring. We'll talk more about this later in the course, but the concern isn't just that the mutations could be severe or even lethal, but that non-visible mutations can be passed on to succeeding generations. So in terms of the effects of diagnostic radiology and nuclear medicine, similar to males, low doses are not going to cause infertility. Low doses from diagnostic radiology and nuclear medicine can cause chromosome changes, and so precautions should definitely still be taken. Radiation therapy obviously involves much higher doses that may lead to chromosomal damage and sterility, and so patients should be warned about the possible consequences of sterility and artificial menopause, and cautioned about procreation to avoid passing on any mutations to their offspring during this time. Next system we're going to look at is the eyes. So the actively dividing cells in the lens of the eyes can be damaged by radiation, and these damaged cells are not removed, and so they build up and form a cataract, essentially making the lens opaque. And cataracts can be seen in some patients with as little as 2 grays of radiation, and a dose of 7 grays causes cataracts in 100% of exposed individuals. While this was more of a concern in the early days of medical radiobiology, the highly radiosensitivity means that patients and folks occupationally exposed to radiation should wear eye shields, especially during fluoroscopic procedures. And in terms of radiation therapy, if the eyes are in the path of the beam, then this would also be something that you would be concerned about. Let's look at the vasculature. So smaller vessels have small lumenins. A lumen just means the opening, so they just have smaller openings, and are more radiosensitive than larger vessels. So damage to the endothelial cells may stimulate the division of the undamaged cell. If too many cells are being replaced, then the blood vessel can become occluded. Right? Occluded just means to be blocked up, right? To block up the pipe. And then the destruction of the endothelial cells may also cause the formation of blood clots that can also occlude the blood vessels. Blood vessels can also hemorrhage, leak blood, or become dilated, which means to become wider. And blood vessel dilation is termed telangiectasia, and is often seen in blood vessels in the skin as spider veins. Vessel sclerosis, or a hardening and stiffening of the vessel wall, can also occur. And just like fibrosis, this is the replacement of normal tissues with connective tissues, so basically scarring. Because blood vessels supply oxygen and nutrients throughout the body, occluding these vessels is detrimental to basically all the tissues and organs that the blood vessels are connected to. We'll consider some more radio-resistant tissues in the next video.